or will we move on? Rania's got considerable experience having worked at the Arrows in the Heart initially and then with Dr. Coselli at Texas Heart. And you're going to talk about the more proximal area and how to deal with it.
So the talk that Vanki asked me to talk about is hybrid procedures and open repair and where we are today, and especially in patients that they had prior ascending repair. So when we talk about the aortic arch, we know that it's actually a very, very small section. You have about 3, 4, 5 centimeters on the outer curve. There is 1 to 3 centimeters on the lesser aortic curve. So anatomically between proximal to the anominate and distal to the left on the subclavian. And of course, when we're planning to repair it, either like hybrid, endo, or open, we have to be aware of the different anatomic variants of the arch, and also about the curvature that can be quite significant in younger patients. And this is important because what really we do on the arch depends on what we have on the proximally or distally. And as we know is that the times that we have to repair the arch in isolation are very few, about 1 to 5%. So most times, most of this approach, there is multiple approaches needed. And the reason is because it really depends on what the proximal aorta looks like, as well as what the distal aorta looks like. And this is the various open repair. This is, we can repair the aortic arch via median sternotomy, but as well as via left thoracotomy. Via median sternotomy is the most common. This is some of the various open repairs. And one of the important things is that we have to be always aware about the brain. One of the main things that always I was asking the nurse every time that we had to do any procedure, hybrid or open, was, is the patient awake? Because really, this is really what it matters. And there is multiple ways, actually, when we do an open procedure to protect the brain. And this is with the hypothermia, as well as different cerebral perfusion strategies. This is on the open repair. On the specialized centers, again, mortality more than 10%, not insignificant, and the stroke around 7%. I think I have shown you this slide before, but this is very important. This is Dr. Nikolai Volodos. He did really the first hybrid procedure on the aortic arch when none of the things that we have today were available in 1991. Actually, he had this thing published. And he used this two-part delivery system with 2 fixating elements at each ends. And I was actually very happy to be at the ICON meeting with Dr. Dietrich in 2013, where Dr. Nikolai Volodos presented actually his different inventions, as well as the long-term follow-up of that first hybrid procedure that he did. So this is on the recent guidelines, and we can see that we repair the aortic arch, of course, when it's symptomatic. And when we look the hybrid or the endovascular repair, this still remains a 2B recommendation, as may be reasonable, again, in high-risk cases. This is with when I was working with Dr. Coselli, and we published that when we look the traditional repair versus the hybrid. You can see that the results are quite comparable. Again, the hybrid was in high-risk patients, and even on the propensity, but the stroke, though, was a little higher on the hybrid group, and that was remained actually still the case even when we did a propensity score match analysis. This is a relatively recent study, and the reason why I have that is from Cochrane, and that they wanted really to see what is out there that compares the hybrid techniques with the open. And the reason that they did this review is because they really thought that is a critical need as a community to see what is the high-level, high-quality evidence out there. And I don't know if you can see actually this ECMO study flow, but they started with more than 1,000 ECMO reports. And you can see on the ECMO slide down there shows that there is like 0 studies included ECMO on the final. And what actually on the Cochrane report they saw is that really there's no any high quality evidence ECMO study, no randomized, of course, ECMO trial that really ECMO compare the one ECMO versus the other one. And really what dictates our decision to how to operate ECMO in a patient really depends on the patient itself as well as the ECMO circumstances. And this is why it's really important to know what is happening and how to do an open repair or a hybrid or even an endovascular, because we'll be able to offer the patient the best care. This is, Vanki said, just concentrate a little bit on the people that they had the prior ascending ECMO graft. So this is, again, one of our studies a few years ago with Dr. Coselli, and we actually show patients that they had the prior type 1 aortic dissection. So they had already an ascending graft in place. So, and we had to do a reduced sternotomy, and one way or another, ECMO fixed the arch. So most of these cases is like an open total arch. You can see the mortality was like 11.7, and any neurologic ECMO deficit, ECMO 6.6, quite comparable in a way with the other studies that I show you. And again, this is ECMO high-risk ECMO cases. The 5-year survival was 32.73 ECMO%. This is ECMO, so this author's ECMO here, that was a little more recent ECMO study. They didn't actually use cardiopulmonary bypass. They did a reduced sternotomy, and they placed a partial clamp on the ascending ECMO graft, and then they put a bypass into the carotid, and then they place a stent ECMO from the femoral ECMO artery. They didn't have any stroke or any mortalities, and they had a relatively good ECMO follow-up. This is from the Duke ECMO group, 71 ECMO patients, prior ascending ECMO graft. Again, ECMO different repairs that you can actually deal with the arch, and a lot, as I mentioned in the beginning, depends what you have proximally or distally. And you can see you can actually do it with on bypass or without ECMO bypass, or a full ECMO blown ECMO circulatory ECMO arrest. One thing actually that was quite, to me, striking here, you can see the 5-year survival in these people is 58 ECMO%. So this is ECMO from, again, Stefan Hallon and his colleagues, prior ascending ECMO repair. The exclusion that more than 70% of the patients are anatomically suitable, exclusion if they are short, if the ascending graft was too short, if there is major kink of the ascending ECMO graft or the graft diameter was too large, but more than 70% of the patients who actually had a good ECMO proximal landing zone, and this is from Austria, when they look at more than 100 ECMO CT scans, patients that they had the prior ascending ECMO repair. You can see ECMO with the current ECMO technology. We use all these fenestrated and branched devices. More than 70% of the patients actually can be done with a hybrid ECMO technique. This is from Huai Hospital, one of the maybe busiest hospital in China. This is interesting because what this actually authors here did, they have 2 groups, and they replaced the ascending aorta in one group. They didn't replace the ascending on the other group. And they wanted actually so they can create a zone 0. And what they found was that in patients that they replace the ascending aorta to create a landing zone, actually that was beneficial for the younger patients as well as for the patients that they had a type B aortic dissection. Again, these were actually normal ascending aortas. I want to show actually something here. This is a hybrid repair that we did with Dr. C a few years ago. But, okay, the conclusion, of course, we have to use the technology. I think there is one video that I want to show, and to really thank Dr. Dietrich for being here. Of course, I would like to thank Dr. Koselli, that I worked with him for 15 years, and really I know a lot about aortas, and to thank Ehmoti Vanki for really inviting me here.
Well, the philosophy of my life has been, under no circumstances, accept mediocrity. Persevere for perfection, regardless of the consequences. Accept the failures, which there will be, but prepare to enjoy the triumphs and the celebrations that also will be encountered.
There's no question that that year actually at Arizona Heart was one of my best years during my training, so I was always grateful for being here. Thank you.